Our next section is congestive heart failure. Now, when we have a patient who in 1970, the mortality on an anterior wall myocardial infarction, the mortality on an anterior myocardial infarction was 20 to 40% of the year. That same myocardial infarction in the year 2000 was 10 to 15% of the year or less. Aspirin resulted in a 25% relative risk reduction. Thrombolytics and angioplasty resulted in a 25% relative risk reduction. Beta blockers somewhere between a 10 and 30% depending on how you look at it. So people are alive. So what has happened is that the survival from myocardial infarction has markedly improved. And what happens is that many of those people are alive and normal now, but many more of them are alive and suffering from congestive heart failure. Now, the most common reason to develop congestive heart failure after you have a normal heart is ischemia. Now, ischemia can take you from a normal heart. How do we go from a normal heart to a congestive heart failure heart? And the answer is coronary disease, ischemia, valve lesions, hypertensive cardiomyopathy. That's dilated cardiomyopathy. Let's look at our first case. We got a 62-year-old man with hypertension, high lipids, non-specific, shortness of breath, more specific. On exam now, he's got jugular venous distension, a gallop, and a displaced apical impulse. Now, the apical impulse should be in the 5th intercostal space. It should be here in the midclavicular line. Midclavicular, that's the clavicle, the middle of the clavicle, 5th intercostal space in the midclavicular line. But if you have left ventricular hypertrophy, the left ventricle, if we look at the heart, hypertrophy is out this way. And what happens is that the point of maximal impulse gets displaced. So what happens is that the point of maximal impulse shifts over because the left ventricle starts to enlarge out this way. And that is why you get an enlarged left ventricle pushing out the point of maximum impulse out to the left. So the question's here. What's the next best step in management for this guy? Well, he's short of breath. And the way to handle short of breath people at the beginning is preload reduction. Oxygen, diuretics, nitrates, and morphine. Oxygen, diuretics, nitrates, and morphine. Oxygen, diuretics, nitrates, and morphine are going to handle preload reduction. 90% of people will get better with oxygen, fluids, diuretics, and morphine. The diagnosis of this guy, S3 gallop, shortness of breath, jugular venous distension, edema, is that he has got systolic dysfunction. Systolic dysfunction and the phrase dilated cardiomyopathy can be used almost interchangeably. It can relax, but it can't contract. Systolic dysfunction is almost interchangeable with the word dilated cardiomyopathy and low ejection fraction. Dilated cardiomyopathy and low ejection fraction, almost interchangeable. Pulmonary edema. Pulmonary edema means you've got fluid bulging out of the vasculature. It's bulging out of the vasculature and into the alveoli. When the fluid is going out of the vasculature and into the alveoli, I cannot breathe. Because what's happening is if this is an artery and this is an alveolus, what's happening is we're having liquid, we're having water going out of the artery and into the alveolus, and it's filling up that alveolus filled with water. Well, how is oxygen supposed to get across that alveolar wall if the alveolus is now a little cup of soup? The alveolus is a little cup of noodles. How's oxygen supposed to get across? Well, the most common causes of pulmonary edema, well, once you have a sick, dead, leaky, weaky heart with ischemia, valvular heart disease, hypertrophic cardiomyopathies, what happens to put you into pulmonary edema? Well, what happens to put you in pulmonary edema is you get more sudden ischemia, a rhythm problem, some form of increased salt load, and that's where we have this issue here of what happens in arrhythmia, more ischemia, increase the wedge pressure. Now, normally, what is the contribution of your atrium to cardiac output? What percentage of your cardiac output is based on your atrial contribution? The answer is only about 10 or 20%. What percentage of your cardiac output is based on your atrial contribution? About 10 or 20%. Now that's if your heart is not sick and dead, leaky with valvular disease, weak with hypertrophic dilated cardiomyopathy. But if it's normal, 10 or 20% is your atrial contribution. Now, if you have a sick, leaky, dead, weak heart, you could have 40 or 50% of your cardiac output based on your atrial contribution. 40 or 50%, which as you go from sinus to AFib, poof, you lose that atrial contribution, flash pulmonary edema. You lose the atrial contribution, flash pulmonary edema. Now, what happens? Any lung disease, you get an increased respiratory rate. That's the same thing as saying shortness of breath. Well, you get a productive cough because all of this fluid in there, see all that fluid in there? You start coughing and coughing and coughing and it gets blood in it too. Why is it pink and frothy? Because it's got a little blood mixed in with liquid. Blood mixed in with liquid. It's like a strawberry smoothie. Okay? So you get cyanosis. When I'm feeling blue, all I have to do is intubate you. Then I'm not so blue. Or when you ventilate me and you oxygenate me. Well, cyanosis, of course I'm feeling blue. I'm feeling blue because I'm suffocating to death. I'm suffocating to death. Nocturnal dyspnea is because I'm lying flat and the blood is pooling in my lungs. When I'm lying flat and the blood is pooling in my lungs, then what happens is that people get paroxysmal nocturnal dyspnea. It's close to orthopnea, but it has to do with a change in position and lying flat. Now, Rales, rhonchi, and wheezing all generally mean lung sounds. It's very hard to have a precise definition of these. Crepitus or crackles, crepitus and crackles are the other breath sound. And this is a hard one, okay? It is a hard one. Now, we have recently released a new set of flashcards because this is the year that multimedia has been added to step 1, 2, and 3. Multimedia means this. Did you know that when you have to take this test, they're going to show you a person's chest, and they're going to say auscultatory point A, B, C, and D. And they're going to say, ready? You put the stethoscope at point this, and you hear this murmur. At point this, and you see this murmur. And say, which of the following is the most likely diagnosis? Or it can say, the patient comes in with the murmur of mitral regurgitation. At which point is this murmur most likely to be found? Or playing the audio tape of that murmur and actually have the image of the stethoscope moving from spot to spot. Now, we were just recently released, which say a set of flashcards on this with audio and videotapes of these things. And the issue is that Rales, rhonchi, and wheezing have almost no precise definition. That word wheezing is defined as a high-pitched sound associated with asthma. Now, I can say that, but if they play it for you, you won't know what it sounds like unless you practice listening. Well, it's a rhonchus, coarser, more gurgling, lower pitched, more like bubbling up like you were, had a straw in a soda and you blow through a straw. That's rhonchi. Crepitus, for those of you who have hair, pull the hair in between your fingers, rub your hair in your fingers, and crepitus or crackles is the high-pitched sound that you get with somebody who has a pneumonia, as the alveoli call pop open like Rice Krispies. Now this is hard. I can say this, but it's very hard to explain. So therefore, we released this year for the multimedia flashcards about the 200 physical finding questions you're most likely to see, and it has all the things that you can need about all the wheezes, the Rales, the rhonchi, all the heart sounds, neurological exams, and every form of physical exam that you could want, and probably everything you'll see on the exam and more. Now remember, as time goes on, those multimedia questions are more likely to get harder, not easier, because in the first few months after the test is released, they're testing it out. They want to see, hey, we don't want anybody to fail. Maybe we're using stuff that's too hard. 6 months and a year later, boom. We know this is what level of difficulty this is. Time to failure. time to failure. Multimedia is here. You will not only be required to know anatomically where, but they'll actually play it to you saying, we auscultated here, and we played this murmur. What is that murmur? And you'll be expected to know. Sights and Sounds of Medicine. Flashcards for USMLE by, Fisher. So on the chest x-ray, we didn't say that you should go to a chest x-ray first with a guy who's got shortness of breath like this. The chest x-ray shows congestion, but you still need to give oxygen diuretics, fluids, and oxygen diuretics, nitrates, and morphine. The x-rays will find big vessels. The x-rays will show an enlarged silhouette. Silhouette is a $5 word for shadow. That's what I said here. It'll show an enlarged shadow. Why is it enlarging? The normal contour here, the left ventricular hypertrophy here. Now, curly bee lines. You notice it's curly with a K-E, not curly with a C-U, like Larry Moe N. Curly bee lines are little horizontal lines in the bases. Curly bee lines are little horizontal lines in the bases that's indicative of fluid.